Thank you for the opportunity to discuss ALG 184. My job got a lot easier today because most of the slides that I was going to present have already been presented. But the good news is I'm going to put a little bit of a drug development perspective on it. So I'm going to present much of the same data you've already seen, but with a slightly different lens on. If we can go to the next slide. Oh, that's me, sorry. So this is my disclosure. I'm obviously an employee of Aligos Therapeutics, and this is our forward-looking statements. Before we talk about hepatitis B, though, I wanted to talk about hepatitis C. And many of you will already be familiar with this, but there's an interesting story here that I think is a good allegory for the development of hepatitis B. So, you know, after sofosbuvir was basically discovered, it completely transformed the treatment of hepatitis C. It went from a disease that was very difficult to cure to just about everyone got cured. But sofosbuvir was an NS5B inhibitor, and it was not the first drug in this drug class. There were actually many, many drugs that were being developed before sofosbuvir, and yet all of those drugs were very disappointing. There was no one really expected until that first infamous phase 2 data from sofosbuvir came out, no one really expected to see those remarkable cure rates that they saw. And the reason for that is basically because these first generation molecules had a number of important liabilities, these ones that preceded sofosbuvir. First of all, they were typically just simple prodrugs, or they were just parent compounds themselves. They had micromolar potency. They didn't phosphorylate pretty well, which is very important with nucleosides. And as a consequence of that, it resulted in this suboptimal efficacy. What was the big difference with sofosbuvir were there really two major things. Number one was it was a much more potent compound. It had nanomolar potency. But then in addition to potency, it also basically was able to be concentrated heavily inside hepatocytes. And that was because it had a phosphoramidate prodrug, so it was easily phosphorylated. It had a high first pass effect. And as a consequence of that, you got very high concentrations of the NTP that then led to the antiviral effects. So the point of my story is that the early classes, that first generation drugs, they just had a number of limitations in terms of potency, but also PK. And as a result, they didn't have remarkable results. But once you kind of cracked that nut and you could figure out a substantial improvement in potency and PK, you had the very dramatic results, which are what sofosbuvir did. So let's talk about capsid assembly modulators, which we've talked about a fair bit today. As many of you probably know, there's essentially two mechanisms of action that are hypothesized for capsid assembly modulators. These have been shown in vitro studies. The first is the one we've been talking a lot about, which is the inhibition of assembly, or the acceleration of assembly of these particles, which prevents encapsidation, and as a result of that leads to reductions in DNA and RNA levels. That's called the first mechanism of action. But it's the second mechanism of action that we've been alluding to, which is this kind of this unicorn that we've been chasing with CAMs for quite some time. And with that, you need to achieve much higher EC50 concentrations in hepatocytes. But if you do that, you stop the establishment of cccDNA in newly infected cells, or you stop the replenishment of cccDNA, because of course cccDNA itself has a half-life. And if you block basically the establishment and the replenishment of cccDNA, you basically will stop antigen levels over time. You'll decrease cccDNA levels, and that in theory should translate into reductions of all the antigens that our cccDNA produces. And so it was interesting when I was preparing for this talk, you know, CAMs have been around for a long time. They've been around for almost a decade now. And basically all we've really seen is these DNA and RNA reductions, which were the first mechanism of action. But we really haven't seen any conclusive evidence about the second mechanism of action. And Harry alluded to this earlier today about some people had even given up on the drug class. They just weren't producing that thing that we expected to see vis-a-vis the secondary mechanism of action. But if we think about the sofosbuvir example, we can kind of put that into context when we look at how our molecule, ALG 184, and there are other molecules that are second generation molecules, how they compare versus the earlier CAMs. You can see here, this is a list of a variety of CAMs that have entered clinical development. And what you can see is that ALG 184 is picomolar in terms of its potency. In fact, it's anywhere between 10 and 300-fold more potent than the first generation capsid assembly modulators. And that really matters when you consider that you need to have at least a 10-fold higher concentration in the liver to achieve that secondary mechanism of action. Now, there are other strategies that we use with 184 to enhance it in terms of PK and getting high exposures in the liver. And it's that combination of when you add both the PK and the potency that we believe you have the real potential to realize that second mechanism of action, which is the thing that has eluded us and we're excited about. So there's a lot of data. It's one clinical trial. It's called the 201 study, and we've evaluated. I won't spend a lot of details on the healthy volunteer experience, but we did a single ascending dose study followed by a multiple ascending dose study. It was very well tolerated, and it had the PK enhancements that we expected, that we designed into the molecule. And based on that favorable healthy volunteer profile, we advanced it into part 3, which was a 28-day study in untreated either E positive or E negative chronic hepatitis B patients. And basically what they got is just like with all the other first generation CAMs, they got 28 days, once daily, oral 184 versus placebo. And what you can see here, these are the pharmacokinetics. You see they're quite favorable. We have a very long half-life. We have linear dose proportional increases in exposure, low to moderate variability, and a low risk of accumulation. This is a good PK profile. And then that ultimately translates into really dramatic reductions in DNA and RNA. Now, of course, all the CAMs do lower DNA and RNA, but as I'll show you in a moment, these are much more substantial than competitor molecules. What you can see here is this is a wonderful dilemma that we have as drug developers. If you see on the figure on the left on DNA, you see equal activity, whether you use 10 milligrams or 300 milligrams. What that tells you is we're on the top of the plateau curve, top of the plateau rather, and we need to actually go down in dose before we find out where it falls off in terms of our efficacy. Now we're not doing that because we're chasing the secondary mechanism of action, but basically anywhere between 10 and 300 milligrams is equipotent from a DNA perspective, and similarly from an RNA perspective. And these are some data. It's admittedly a cross-study comparison, but what we did is we looked at the DNA reductions of the first-generation CAMs versus our CAM, and what you can see is that 184 is able to achieve DNA reductions somewhere on the order of up to 1 log, at least a half a log to 1 log, greater reductions in DNA compared to the first-generation CAM molecules. And you can also see that a much higher percentage of subjects are below the lower limit of quantitation. But perhaps what's most remarkable about these data is we're doing that at the 10 milligram dose versus up to an 800 milligram dose with the first generation CAMs. We believe that's a direct indication of the enhanced potency and the PK of the molecule, where you're basically able to achieve much more with much less drug because of those second generation attributes that I mentioned before. But what got us really excited was actually the surface antigen data, which is part of my talk. And what we saw here, again, was this was our first evidence that perhaps this unicorn of the second mechanism of action truly exists. And what you can see when you look at the, there's actually 2 cohorts. I'm not going to do that. There's 2 cohorts represented here. You've got the 100 milligram cohort. You had a single subject. And if you look at the bottom row there, you see a very nice surface antigen decline over a 28-day period. They had about a half a log reduction. And you don't typically see a half a log reduction in surface antigen over a 1-month period of time. But equally importantly, you also see 4 out of 8 patients have surface antigen declines in terms of in the highest dose cohort, the 300 milligram cohort. And you see that some people had up to a 0.8 log reduction. And so we're seeing in 50% of patients, we're seeing that we're having surface antigen declines over a 28-day period. And this is tantalizing evidence that perhaps we're hitting the second mechanism of action. It's not definitive, however, and we felt that we needed to do longer term studies in more patients to look for evidence of that. So what we've been doing now, we have many cohorts that are ongoing right now. I'm going to highlight the data from our longest running cohort. This is cohort 2. It's being run in China. I should have mentioned before, those S antigen declines were only in E positive subjects, okay? And so here, this is an E positive cohort of 15 subjects. And what we did was we randomized these subjects to either receive entecavir monotherapy or the combination of 300 milligrams of our CAM plus entecavir. They got that regimen for 12 weeks, and at the end of the 12 weeks, they rolled over into an open label regimen for a total duration now that's planned for 96 weeks. I'm not going to show you those data yet because we haven't dosed that long yet, but we have permission to go out to 96 weeks with this regimen. And what you can see, as you might expect, and was consistent with what I showed you a moment ago, when you look from a DNA perspective, what you can see is much more substantial reductions of the combination of the CAM plus entecavir, which is represented by the blue line, relative to entecavir alone, which is the orange line. And what's interesting, you should get about an extra log and a half reduction with the combination there. But what I think is even more elegant is the fact that these subjects rolled over, and then you can see the orange line basically converging with the blue line. So that's clearly telling us that these DNA effects, these DNA lowering effects, are driven by the CAM. Now, in the interest of time, I'm going to go ahead and skip the RNA data, but they're very consistent with what you might expect, where you see substantial reductions with the CAM, but no reductions with the nuke, which is what you would expect. But the surface antigen data, I think here, this is an extension of the data and an even more impressive evidence of S antigen lowering. What you can see here is we've now dosed subjects, these were presented at EASL, we've dosed subjects at this point out to 36 weeks, and you can see really substantial declines in surface antigen and also very consistent effects. You can see that approximately half of subjects are having surface antigen declines, and in fact the maximum decline is now at 2 logs, which is very similar to some siRNA. Now, this is not our mean at 2 logs, but we're able to achieve 2 log reductions in surface antigen using this CAM molecule. These data are, of course, were very exciting to us at the time at EASL. They were presented as a late breaker, but I think equally exciting to us, this has been alluded to several times now, is that we're actually presenting additional data. They're embargoed, but the title really tells you the whole story if you just read the title. So what suffice it to say, we're continuing to see evidence of cccDNA effects, which we think really is convincing evidence that CAMs, when you do a second generation molecule, have the capacity to really realize the full potential of the drug class. So just to summarize, with the drug developer's hat on, and I'll wrap up in just a second, the CAM class was initially a little bit disappointing because all they showed was the DNA and the RNA reductions, but that's because they weren't particularly potent and they didn't have the right pharmacokinetics. But once we started inventing molecules with enhanced potency and better PK, we were suddenly able to realize these harder to reach effects via the secondary mechanism of action because we were physically able to get a high enough exposures in the cells to actually measure that secondary effect. So 184 has been well tolerated, and so we're actually initiating efforts to start up a phase 2 study. But what I love about this as an example is it's very similar to the sivosbuvir story. Once you come up with a better molecule in terms of its potency and its pharmacokinetics, you can really realize the full potential of the drug class. Thank you.